Advent on Air, the science of type 2 inflammation on the go. Welcome to Advent on Air, a podcast featuring conversations between leading experts on the science of type 2 inflammation. Today's episode features a conversation between esteemed dermatologists Dr. Donna Culton and Dr. Russell Hall on the heterogeneous presentation, diagnosis, and burdens of bullous pemphigoid, BP. This program is non-promotional and is sponsored by Sanofi and Regeneron Pharmaceuticals Incorporated. The speakers are being compensated and/or receiving an honorarium from Sanofi and Regeneron in connection with this program. The content contained in this program was jointly developed by the speakers and Sanofi and Regeneron, and is not eligible for continuing medical education CME credits.
Hi, my name is Donna Culton. I'm a professor at the University of North Carolina at Chapel Hill in the Department of Dermatology, where I see and specialize in patients with autoimmune blistering disorders, including bullous pemphigoid. I also run the immunofluorescence lab where we diagnose many of these patients, and I'm delighted to be here with Russ Hall.
Hi, I'm Russ Hall. I'm professor of dermatology in the Department of Dermatology at Duke University, where I also specialize in the treatment of patients with autoimmune blistering skin diseases, and I've had a long-standing interest in investigating the pathogenesis of the disease, as well as trying to develop and implement new therapies for patients with autoimmune blistering diseases such as bullous pemphigoid.
Great. So Russ, in your years of seeing patients with bullous pemphigoid, tell us about your clinical experience, how these patients present.
Well, bullous pemphigoid is a really interesting autoimmune blistering disease. It presents predominantly, but not exclusively, in patients that are above the age of 60 and will present as an extremely itchy, diffusely itchy dermatitis that has a highly variable clinical presentation. Most of our patients, as well as most of the patients in the literature, present with what I call the classic form of bullous pemphigoid, which is relatively large blisters, oftentimes with an erythematous background, a red inflammatory background. They're generalized over the extensor surfaces of the body, but also the trunk, and are extremely itchy, as is the common sign of most forms of bullous pemphigoid. They are tense blisters, so they oftentimes don't rupture. But when they do rupture, sometimes there's actually healed skin that shows up underneath the ruptured skin. So they're always reepithelializing as we go along. 10 to 20% of these patients may have some mucous membrane involvement, but it's generally not the predominant part of the disease. It's more secondary. It can be very disturbing, but it's not the primary clinical lesion that they have. And indeed, I always tell our residents and other clinicians that if you see someone that is mucosal predominant, has very little skin disease, you should consider other things such as mucous membrane pemphigoid or epidermolysis bullosa. There oftentimes will be, after the lesions heal, some dyspigmentation or post-inflammatory changes. And because the disease is exceedingly itchy, you may see clinical findings typical of excoriations in these patients also. Now, the interesting thing is 20 to 30% probably of patients have a non-bullous or a non-blistering type of presentation. And these lesions can be widely variable, ranging from urticarial type lesions, eczematous type lesions, hypertrophic prurigo nodularis type lesions, and they can really be quite varied, and they can also be quite localized. So this is a lot of the patients, and these patients oftentimes are not diagnosed very quickly and can linger and have persistent severe itching. So that's the general clinical presentation that we see, a very variable presentation with the majority having the classical blistering kind and a significant minority, 20 to 30% of patients, having anything from typical hive-looking lesions to prurigo nodularis type lesions and a wide variety of other mixtures of these kinds of lesions. Donna, does this fit with your findings or what you see clinically in patients with bullous pemphigoid?
Yes. As you were mentioning the non-bullous clinical presentations, I was thinking back to training in residency, and we were told that oftentimes this non-bullous presentation was a prodromal phase of the disease. And what I think as we're recognizing more of these patients that have non-blistering or non-bullous clinical presentation with more eczematous or urticaria eruptions, that many of these patients, it's not a prodromal phase. Often they don't go on to develop blisters. And so I think those are the patients that we would potentially miss if we're not really thinking about the non-bullous clinical presentations. And as you said, it can be difficult, but if it's an older person with a new pruritic eruption that is not well controlled, certainly we need to be thinking about bullous pemphigoid.
Well, with that sort of segue, critically important is how we diagnose bullous pemphigoid, and how do you proceed in the diagnosis of this widely variable patient population?
Well, I'm kind of a purist, but that has been challenged as we've recognized these non-blistering presentations. But typically, we would start with the clinical presentation, right? So a blistering eruption in an elderly patient raises our suspicion for bullous pemphigoid, and then to confirm the diagnosis, really relying on a biopsy for routine histology, so biopsy for H&E, a biopsy for direct immunofluorescence on perilesional skin, of course, and then serological studies, so either indirect immunofluorescence, ideally on salt split skin, or ELISA. I like when we check all of those boxes, right? That's my favorite way to make the diagnosis. But with the non-blistering presentations, we have to keep in mind that not only is the clinical presentation challenging to recognize, but routine histology may not always show the subepidermal blister that we're used to seeing. And so you really need to rely on direct immunofluorescence to make the diagnosis in those cases. I think another important part is to mention a thorough review of medications. There are increasing reports of drug triggers. The DPP-4 inhibitors or the gliptins are a big one. Checkpoint inhibitors, so classic loop diuretics, NSAID. And even in the best of circumstances, sometimes those can go unmissed or it's not in the patient's history. So important to do a really thorough review of the medications that they're on. But ideally, we're confirming the diagnosis with direct immunofluorescence with supporting histology and serological studies as well. Is that how you handle the diagnosis? And how do you approach the heterogeneous presentation of bullous pemphigoid when we're trying to make the diagnosis?
The diagnosis, as you described, is really a combination of a good medical history, an appropriate physical exam and recognition of the history, and then the histology and the serology and the immunopathology. So really, this is not something that can be diagnosed in many patients just by looking at them or just by getting a biopsy. It requires all of those components together. The heterogeneous presentation, I think, is really difficult. How I handled it is try to focus on what I think are the two key elements of the disease. Number one is the age of patients. There is a giant increase in the frequency of BP and the incidence of BP in those less than 60, which is about 1 per 100,000, and up to about 60 to 100,000 to those over 80, and continuing to increase as age increases. So this is a disease that's focused on the elderly. And the second thing is a severe itch, an itch that's refractory to common therapies, an itch that won't respond to an antihistamine or a topical corticosteroids very well, that goes on and on. Even a quick burst of steroids won't resolve the itch. It comes right back. This chronic itch in an elderly patient should be the keystones for going for these other diagnostic tests. If you see those elements in our practice, we go right away to the skin biopsy with routine histology and direct immunofluorescence, and oftentimes directly to the serology too, because this incidence is so high and the ability to treat it early is so important that these are really important elements to go after.
Russ, what do you think of, increasing availability of ELISA? How is that impacting diagnosis or misdiagnosis of patients? So do you think you can make a diagnosis of bullous pemphigoid based on ELISA alone?
That's an interesting question. And I think that all of our diagnosis of bullous pemphigoid, I think, rely on three elements. The first is the basic demographic conditions of the patient. The second is what's going on in the skin. And the third is how is the clinical picture consistent? The clinical picture, we said, is very variable. And what's going on in the skin, I think, is more critical than what's going on in the serum. And then putting them all together is what leads to the diagnosis.
I really like a positive DIF And so there's times where a patient is referred to me with suspicion of bullous pemphigoid, maybe not full-on blisters, but itchy with some variable dermatitis of some sort, but then a positive ELISA. And I am always wondering, do I need to do that direct immunofluorescence to prove it? I often do, mostly because of the risks of the medications we're about to put the patient on. I really want to make sure that we have the right diagnosis moving into treatment phase. But just was curious to hear your thoughts.
Yeah, well, I think that one of the critical elements is that despite all the serologies and all the things that we know going on in the blood, it's the patient's skin, whether it's blistering or not, or whether it has immunoreactants or not, is a critical element. And we know that a small number of patients may have these antibodies. And if they have no disease in the skin, and if they have no immunoreactants in the skin, it's hard to say that they have bullous pemphigoid. They may have bullous pemphigoid antibodies, but not the actual disease. So I think we need all three. You need the clinical presentation, you need the immuno and histopathology in the skin, and you need the serologies. And then putting them together, the clinician can make the diagnosis. Leaving any one out is difficult, and I think that's the key. Delay in diagnosis is tough. The disease is very itchy. It's very disruptive. The patient is miserable. The patient's family is miserable. And so we really need to get the diagnosis as soon as possible. And it also appears the longer you take to diagnose patients, the harder they are to control. And so it is really incumbent upon us to make the diagnosis as early as possible. And one of the key ways to do that is if it's severe itchy in an elderly patient, bullous pemphigoid should always be in the differential diagnosis. You won't always find it, but it should always be in your differential diagnosis because we can treat it. And if we don't, there are severe consequences. One of the elements of this disease and the severe consequences of being in the elderly population are comorbidities and other things that go along with the burden that the disease places on the patient. Donna, how do you work around all the disease burden that this causes for our patients and the comorbidities that they experience?
As you described, this is a really challenging disease in a really medically fragile patient population. We are recognizing now that this disease has an increase in mortality in these patients compared to their peers. What we really need to know is who do we need to be worried about among our BP patients? The risk factors for increased mortality are older age, of course, poor overall health. These are things you would guess would portend a worse prognosis for the patients, but also a higher serum anti-BP180 IgG that you can detect on ELISA, and then a higher dose of systemic steroids or steroid-sparing agents required. So, of course, the more immunosuppression, the worse outcome for these patients. And as you said, a delay in diagnosis often means we have to use higher doses to control the disease. So it really is a double whammy for these patients. Many of the comorbidities that have really gained traction over the last 10 to 15 years include neurological conditions. And that's a variety of diseases, including stroke, multiple sclerosis, Parkinson's disease, dementia. All of these are associated with increase in bullous pemphigoid in these patient populations. But there are also non-neurological conditions we need to keep in mind. There's an increase in cardiovascular disease, diabetes, malignancies, and other autoimmune diseases in these patients. Many of these things are already prevalent in an older patient population, but there's some nice studies showing that these higher rates of these diseases in patients with bullous pemphigoid. The disease burden complicates the management. We see this in clinical practice. How do you work around some of these comorbidities when you're trying to come up with a treatment plan?
The comorbidities are really the most challenging part of managing a patient with bullous pemphigoid. The disease comes under fairly rapid control with high-dose systemic corticosteroids. But the flip side is all the major side effects of high-dose systemic corticosteroids are made much worse by the comorbidities of our patients. So the patients oftentimes will have diabetes, which is difficult to control with high-dose corticosteroids, or hypertension with sodium retention, and which also makes their heart failure worse. So all of these sort of changes that go along with it oftentimes dictate a more rapid taper than you would like to do, which means flares come up and you have to go back on higher doses. Right now, we have systemic corticosteroids as our main therapy, and this presents lots and lots of problems for these comorbidities. And additional steroids in themselves have a lot of problems for the patients. They cause mental status changes in the patient, oftentimes difficulty sleeping. The mental status changes affect the family that's taking care of them, affect the patient and his ability to interact with his loved ones or her loved ones. And it just is an incredibly difficult part of managing these patients. The second part is the disease itself presents a lot of difficulties to families. Managing a patient with blisters over 50% of their body that are blistering constantly, that are itching, and that are draining fluids and having open wounds is really difficult for the patient and their family. It's a real problem that really dictates having a fast and effective therapy. We mentioned slightly the mental health burden, which is exceedingly important. There's an impaired quality of life. It doesn't take much to imagine that being blistering and itching doesn't let you go to the grocery store or go out to visit friends or family or have your family over for dinner. There's a lot of decreased socialization, which in this elderly population can be quite devastating to be isolated like they are. There's a lot of anxiety. Am I going to have this for the rest of my life? Is this ever going to go away? How is this going to help me? How am I going to ever get over this? So all of these things are really focused on the severity of the disease and the difficulties with the treatments. And it really requires just a constant look at the whole patient, their whole medical condition, and what else is going on with them. So this is a very complicated issue and one that really requires of the physician the willingness to work with the family, the patient's primary care provider, plus a lot of times specialty physicians that are taking care of their other problems. So this is complex, but it is doable. But we always have to remember that the side effects are as important to look out for as are the manifestations of the disease itself.
No, certainly. I think there's a huge challenge when caring for these patients, and certainly some unmet needs in terms of our treatment options here. So again, recognizing the early diagnosis and treatment are really critical to minimizing the risks with the treatments that we have available right now and improving the long-term outcomes of these patients.
Well, I think that one of the things that's clear to us and to those of us who see lots of patients with bullous pemphigoid is that there is a big unmet need to managing these patients quickly, but there's also an unmet need or ability of the medical profession, both in dermatologists and non-dermatologists, to recognize the disease early. So I think that if we can recognize the disease before it's severe, before they're covered with 50% blisters, before they've been itching for 3 to 4 to 6 months, we can minimize the use of systemic corticosteroids, hopefully put our patients into control to minimize all the effects of their comorbidities that they have on the prolonged use of systemic corticosteroids. So it's a challenge, but I think on the flip side, it's a very satisfying disease to manage because when the patients do get better, you're returning them to a normal life, which they were worried that they might not ever get back to. So recognizing early diagnosis, effective early therapy, and watch out for comorbidities. The bottom line lessons, I think, for patients with bullous pemphigoid.
Thank you to our esteemed guests, Dr. Culton and Dr. Hall, for your valuable insights on the heterogeneous presentation, diagnosis, and burdens of bullous pemphigoid. Thank you for listening to Advent on Air, providing the science of type 2 inflammation on the go. If you learned something from this, leave a review and subscribe to Advent on Air to hear new episodes on Spotify, Apple Podcasts, and adventprogram.com.